right, thank you. Somebody said they could see it. So if you can't, just let me know. All right, so now we're going to talk about bulimia nervosa, okay? So in the DSM-4, it was categorized more by the two major types, purging or non-purging. Now what they do, they focus on severity. Just like I showed you with anorexia nervosa, they do the mild, moderate, severe, and extreme severity based on usually the BMIs, okay? Here it includes the compensatory behavior, and we're going to talk about that here in a minute. Okay, so a little bit about bulimia. The mean age onset, we see usually it's a little bit later, so like 18 to 21. So usually the patients are a little bit older than the 16 range that we said before. Gender differences, it's still the same with majority account for female, but we do still see it in the male population, so you want to keep that in mind. Ethnical, cultural, it's the same like we talked about. We see it, of course, more in Western cultures. Comorbidity, we see it more with substance abuse and dependence, which we said that as well with anorexia. OCD, which was another one we said. One that we didn't say that we see a lot with bulimia nervosa is personality disorders or access to disorders. So personality disorders, I think that is our topic in about 2 weeks. So we'll be talking more about that, but this is going to be like borderline personality disorder, things of that nature. Okay. And then last but not least, we see it comorbidly a lot with anorexia nervosa. So like I said, lots of times when people go into remission, if you will, from anorexia, if they don't pass away, then lots of times they'll end up going on to bulimia. Okay, so we're going to talk about, in a minute how those are a little different. Okay, so first, bulimia nervosa. This is a recurrent episode of binge eating. So binge eating, I'm going to define for you. Your book talks about this as well, so don't freak out in trying to write down everything. But it is a rapid, episodic, impulsive, and uncontrollable ingestion of a large amount of food during a short period of time. So this is usually about 1 to 2 hours, okay? And then it's followed by feelings of guilt and remorse, which then lead to inappropriate compensatory behaviors to prevent weight gain, such as purging and non-purging behaviors. So the purging and non-purging behaviors are just like we talked about with anorexia. You see the vomiting, laxative use, diuretic use, they self-induced vomiting, and non-purging is more fasting or over-exercising. Okay, I will tell you that we see more of the purging types with bulimia and non-purging with anorexia, but that is not what makes them different, okay? Because you can still have non-purging with bulimia and purging with anorexia. So I'm going to tell you that here in a minute. They find that binge eating and inappropriate compensatory behaviors occur on average for at least 1 time a week for 3 months. So they have to have it at least once a week for 3-month period. Okay, so here's how it's a little different, and this is one of the biggest reasons that it's different. Okay, somebody that has bulimia nervosa, they're usually normal weight. So when we go back to that BMI, that is going to be what differs. When somebody's has anorexia, they're usually less than 17. Okay. When somebody has bulimia, they're usually normal weight or even sometimes overweight. Okay. But we do still see some of these other changes in physical assessment. They can have hypokalemia. Of course, that's going to be due to purging. Dental caries or erosion, this same thing is going to be due to the self-induced vomiting, okay? Lots of times they get calluses on their fingers, okay? And think about a callus. That happens when you do something over and over again for a long period of time, right? We're not talking once or twice. So to actually get calluses on your fingers or hands, due to self-induced vomiting. I mean, we're talking, this is a major issue, right? So that's something to keep in mind. That's actually called Russell's sign. Um, they can have cardiac failure if they're deaths. It's usually due to that, due to EpiCat toxicity. EpiCat, you probably don't know what it is unless you're an old lady like me. But EpiCat, it was like everybody's mother and grandmother had EpiCat in their medicine cabinet. Okay. You can still buy it, but it's not as readily available as it used to be. But EpiCat, it was like everybody needed to have that, because if your baby or your child got into medication or drank something or ate something they weren't supposed to, you would give them EpiCat. And EpiCat actually makes it induces vomiting. I'm sorry. So, the problem is people with bulimia nervosa or people with eating disorders, lots of times were then actually abusing it. And so over time, what happened, they said, okay, well, we don't need to make it so readily available to to everyone. So they took it off. You can Google it and you can still buy it. I haven't looked at that just to see. So it's not as easy just to go to the drugstore and get it, but you can still get it. So anyways, I just kind of put that out there because I'm always interested in things like that, because people who really want it, they're going to get it one way or another. Parotid swelling, you remember that's the hypertrophy of the parotid glands that causes chipmunk cheeks, and then hyponatremia. So those are some things we want to look at. Now, if they're hospitalized, usually people with bulimia nervosa, they usually aren't hospitalized. If they are, it's usually more due, like we said, cardiac failure due to toxicity of some agent they're using, or due to the hyponatremia or kalemia. Okay. Psychiatric wise, what are we going to see? Okay. When we talk to them, we're going to see about binge eating behaviors. Usually they do it in private, but you want to ask about how many calories are they taking in. They usually take in a large amount of calories in a short period of time. We want to question about, anxieties and compulsive behaviors. So one reason why they think OCD is somewhat linked maybe to bulimia, especially because of the purging behaviors. But you want to think about when somebody purges, okay? They eat a lot, and then what do? They have these thoughts in their heads, and then they vomit. So it's an obsession and a compulsion. So they think that a lot of this might be a cause of anxiety and compulsive behaviors. So remember that, because that's going to come back in a little bit when we talk. We want to talk to them about dietary restrictions that maybe they practice, their sleep patterns, their cognitive issues. Are they using laxatives? Laxative abuse can actually be a problem because it will cause major severe constipation in time. I did endoscopy years ago. If anybody has ever seen endoscopy, if you've seen somebody that has that abuses laxatives, it's pretty interesting. I'll never forget, every time I would see it, it would be really cool looking. But when you look at the, mucosa, when you look at the GI tract, and you're doing a colonoscopy, it should be pink and moist, right? Okay, just like in your mouth, things of that nature. We expect it to be pink and moist, okay? Somebody that has abused laxatives, what actually happens in times is up in the rectum, it will actually start to turn into very, very thick mucosa, and it actually looks more like a snake skin. And so when these people get scoped, it's very obvious that when somebody abuses laxatives, because you can see it in their rectum area, and it looks like a snake skin. It doesn't look like that nice pink mucosa that you usually see. So it's kind of interesting, I think. Impulsive behaviors, usually it's not just about eating. They have it all in their life. So where do we see impulsive behaviors? We can see that with sex. We can see that with substance abuse. We can see that in many different areas. So that's something we want to think about as well. Problems with relationships, we talked about chemical dependency, and then disturbed cognition. We want to look for those cognitive distortions as well when we're interviewing them. Nursing diagnosis. So if we think about nursing diagnosis again, decreased cardiac output could happen. And that would be if they had like a toxicity, disturbed body image, powerlessness, chronic low self-esteem, anxiety, like we said before, ineffective coping. So there's a lot of different diagnoses there to think about. Short-term goals, of course, attain normal electrolyte balance. That's very important because we see the hyponatremia. I keep wanting to say Katrina because I'm saying natremia, but hypokalemia. I'm sorry. There we go. And then, of course, short-term refrain from their binge and purge behaviors. So lots of times this is something that we still see in St. Clair. If we have somebody who has a history of bulimia, their doors get locked 30 minutes after meals. They can't go to the bathroom unless there are one-to-one during that time. So those are things that we think about. Always, though, medical stability first. Okay, I think that's pretty self-explanatory. Long-term, of course, reduce and eliminate that binge purge behavior. That's going to take time. It doesn't happen overnight. And then we want to address any coexisting issues like the depression, substance abuse, anxiety, low self-esteem. So that will come in time, but like I said, it's not going to happen overnight. Different interventions. I already talked about how we try to interrupt the binge purge cycle by we have our normal meal times. We have them scheduled in the psych units. They get a regular diet, of course, unless they if they're diabetic or something like that. But we try to avoid restricting calories in certain diets because they will come up with anything under the moon that they can and can't eat because of their eating disorder. They're so fixed on it. Everybody comes and sits together. Nobody's eating in their room, isolating, because that happens a lot too. They have groups that they discuss food and they discuss maybe irrational beliefs they have about that, in which the social worker will talk to them about as a group. But this is where a lot of their therapy is focused, the cognitive therapy. Med-wise, what we see a little different for bulimia is I do find that they use more SSRIs, and it's usually because age-wise. Now they're still going to keep tab on their age, of course, to see where they are, but usually they're a little bit older, so they will put them on SSRIs. And we do find a lot of times that they'll give an SSRI at a high dose. Now, there was some disorder we talked about that we saw SSRIs at high doses. Do y'all remember what that was for? Come on, somebody. Yeah, I'm not getting any answers. Come on. Somebody give me something. Y'all still there? It's actually going to be OCD. Remember, we talked about OCD, that Prozac, they'll give it at high doses, or Luvox, something of that nature. So the thought behind it is the OCD reasoning, okay, which to me makes sense. Zoloft's another one they'll use. The biggest thing we have to watch is side effects. We talked about the weight gain, things like that. But also sometimes SSRIs will cause nausea in people, especially at the beginning. So that's something else we want to watch. We don't want them just to stop it and not tell their doctor. So we really have to talk about side effects. Something with Zoloft that's interesting is they have found that it reduces the frequency of binges and the overall severity of the illness. So I think that's pretty interesting. So you will find that Zoloft and Prozac are the most used if they can. Um, they find, of course, bulimia nervosa safety is going to be at a higher risk for suicide. We also see a lot of self mutilation, and remember I talked about axis 2. We see a lot of axis 2. Well, axis 2 personality disorders, especially certain ones that we see with bulimia frequency, like borderline, lots of times they are self-mutilators, meaning they cut or hurt themselves in some way. They're not trying to kill themselves. Usually they're going to tell you they want to feel pain or see blood. So that's something to kind of keep in mind. But usually I find people that self-mutilate in time, it is a safety issue because usually they end up killing themselves even if they don't mean to, by ODing, taking too many pills when they really didn't mean to or whatnot. So you still have to watch these people very closely. Also, high levels of impulsivity, like we said, so that affects all areas of their life, legal issues, maybe financial difficulties. So those are things we want to watch for as well. All right, binge eating disorders, where we're going to kind of end. And I hope, let me make sure this is right. Give me 1 second. I want to look at the book here because that's not the right page. I had the wrong page on here, y'all. I'm sorry. I did not change this. Give me 1 minute and I'll give it to you. 33. So with the binge eating, like I said, it is new in the DSM-5. It's on page 346. The criteria is on 347. So just change that. If it's in your outline listed that way, I apologize. This is when people have recurrent episodes of the binge eating, like we talked about. They have like a large amount of calories all at once. But we talked about that guilt. They still have the guilt, but they usually do not engage in purging behaviors. If they do, they don't do it as often. Okay. So, of course, over time, obesity, morbid obesity is a factor with the binge eating. The severity is based on how many times they do it a week. So, like mild is 1 to 3 binge eating episodes a week, extreme is 14 or more. So we're talking big time, right? This isn't something small that we're looking at. Also with this, we see a lot, if they're hospitalized, it's going to be due to their comorbid conditions due to the binge eating. So of course, their high cholesterol, their hypertension, their osteoarthritis. I mean, it's going to be due to another issue usually. Of course, they end up dying usually of heart problems and things of that nature because of the binge eating and the obesity. So something to keep in mind. I'm very glad that they now consider this an eating disorder. I find, though, that they still aren't treating it as such, meaning that you do not have people go to eating disorder facilities or units and say, hey, I have a binge eating problem, right? Here in the Western world, what do? We make accommodations for everybody. So, you don't want to be prejudiced, but then at the same time, we're prejudiced against the person that has anorexia nervosa, which I do not think is fair. I usually show a video in class, and it's an old video. I laugh. I still have it on VHS, and like half of it's worn out. So it takes a while to kind of kick in. But it's an old Oprah video, and I like showing it because it shows how our society reacts to people that have eating disorders. So first they have somebody that is anorexic, and she's like 70 pounds. And Oprah is pretty, Oprah likes to be a therapist at times, and she's being Oprah and being a therapist where she shouldn't be, when she shouldn't be. But it was amazing to see the ridicule and how everybody reacted towards this lady, especially Oprah, that was 70 pounds. Very kind of like rude, would say things like, how can you not think this is affecting your child? Like almost like she wanted to slap the lady across the face. It was just kind of crazy. And then the next segment, she had somebody that had binge eating or eating disorder, but before it was a disorder. And so it was a lady that fought with obesity. And she was like, oh, yeah, child, I totally understand. I feel the same way that you do about eating. You can see my weight go up and down. You see me like a roller coaster. And she goes, I totally relate to you. And the therapist that was on there, she had her on pretty frequently, but it was pretty interesting because I'll never forget, she was saying, but Oprah, you're dealing with the flip side of the coin. One's not eating and then one's eating too much. And then Oprah acted like, oh, yeah, I understand. But then she was still so hard on this lady that had anorexia nervosa and totally relatable to the one that had binge eating. So it was interesting to see how in our culture, how I still feel like people react, because I would be interested. I have not done the research myself, but to look into see how many binge eating disorder clinics there are compared to, we look at it as it needs to be fixed. It's not my problem. Society has done it to me. I need a lap band, or I need, we kind of look at it more like that than, hey, I need to go get psychological treatment for. And that's my opinion, but I think that's a lot what we see. Does anybody have any thing they want to add about that? No? Everybody's so quiet. I'm putting everybody to sleep, I guess. All right. And I just want to end talking about the issues that they do have in the field of eating disorders. There is a huge lack of funding. The National Institute of Mental Health, the budget for eating disorders is less than 1%. So that tells you already they're getting nothing. You need to think how much do you think the budget is for mental disorders in general? We know it's not a lot, right? So to know that the funding is less than 1% of the National Institute of Mental Health's budget, I think is just like mind-blowing to me. This is another disorder like substance abuse, and the fact that a lot of people feel like eating disorders, people do it to themselves. I tell you that because it is one that I find of the mental illnesses like substance abuse. If you do have insurance and you look at your health insurance, usually it isn't covered. Or so you have to pay out of pocket, and it's very expensive, and it's usually a long-term treatment, kind of like substance abuse. So very interesting there. And we see a lot of relapse. Here's just some resources. I'll tell you, we are actually lucky enough to have a really well-known eating disorder unit in our state. It's actually at River Oaks in New Orleans. And I put a link here that you're able to look up if you're interested just in the treatment options they have. They do actually even have a specialized track for male patients, which I think is pretty incredible. So there's just not a lot out there. And so, of course, it's expensive and hard to get in. So I did get a question. Have you noticed an increased number of people with binge eating because of the new eating trend? Can you be a little more specific? What do you mean by eating trend?
Like there's people like posting themselves of like they're posting videos of themselves, like it's called mukbang. And they post videos of mukbangs. Have you heard of them?
No. Can you write it out as a chat? I'm sorry, I can't understand. Because I'm gonna look it up. Mukbang?
Yeah, people like post videos on YouTube like eating like a ton of food in one sitting, and they'll just talk about whatever they want.
That's very strange.
Yeah,
I'm gonna
like a bunch
write that down and do some research about it.
Yeah,
Thank you for sharing that. Has other people seen that and noticed that?
Yeah,
it's pretty kind of like a trend.
I think it's pretty like, I don't know. I think it's pretty popular to know about it. I don't know.
Okay. Yeah, people have said people are like chiming in that they've seen it. So that's interesting. I'm going to definitely
Yeah.
look into that. That is something new for me. So I appreciate y'all telling me these things because I don't always know what's going on out there sometimes.
Yeah.
So I will look into that. Any questions or anything? Like I said, by the end of the day, I will have that Google Doc up for you to go ahead and sign up for your group project. Okay. And if there's any questions, just shoot me an email. All righty. Well, I hope y'all have a somewhat relaxing spring break, get a little bit. And somebody asked if I'll post the Google Doc in the email or under a new tab. I'm probably going to send an email out to y'all. But y'all have a great break. Try to relax a little bit. And hopefully you can start your group project, and the fact that it will help with a little of your mental health, because we all need that right now. All right. So take care, and let me know if you have any questions. All right. And I'll be shooting y'all some emails. All right. Have a great Easter and great break. Thank y'all.
Miss Jusa.
Mm-hmm.